Good afternoon, and welcome to today's Critical Conversations. What's old is new again. Vaccine Preventable Diseases, or VPDs. We are so glad you're with us this Friday, June 20th, 2025. We have 12 p.m. to 1 p.m. to bring you some wonderful information from today's presenter and get some questions answered. And on behalf of CDPH and our colleagues at the California Immunization Coalition, welcome. We'll move to the next slide. And my name is Leslie Amani. It's my pleasure to facilitate today's call. And I'm joined by a wonderful webinar support team today of Michael Fortunka, Blanca Corona, and Diane Evans. And we are here to support today's presenters and our subject matter experts. If you have questions that come up, please use the Q&A icon. It might look a little different for each person, but that is accessible for you to ask questions, get clarification, make comments. We use the chat for links. So the chat is closed to you, but we will drop links in as we go along. And of course, reactions are always welcome. So if you can hear my voice and you're ready to get things going, please choose a reaction as we move on to the next slide. And with 130 and counting, I see some reactions popping up. Happy Friday. We want to remind you we are recording today's session. And for this and previous crucial conversation slides and webinar recordings, go to the IZ or Immunization Provider Webinars page on EasyIZ. We also want to get you added to the CDPH email messaging listserv for providers, so please email that request to Blanca Corona. Blanca's email is on this slide, and if you have any post-webinar related questions, please reach out via email to Diane Evans. Next slide. All right, getting right to it. Today we are welcoming Dr. Jasjit Singh on the VPDs, Vaccine Preventable Diseases, What's Old is New Again. Dr. Singh will present, and then Tarisha Gamboa will join us to bring resources together for you. And then we will have discussion and questions and answered with Dr. Singh and CDPH subject matter experts. Hopefully you can see Dr. Singh and Tarisha on screen at this time. We'll be wrapping things up at 1 p.m. So again, thank you for attending, and we're going to move right on to our next slide. And we have a poll to kick things off. That's right. Look for those polls. There are 3 vertical bars. How confident are you in your ability to speak effectively with patients about measles, pertussis, and varicella vaccines? Very confident, confident, somewhat confident, slightly confident, and not confident. And by the way, we're just beginning. We're hoping to equip you with some great information. If you choose not confident, that's an honest answer, and we appreciate honest answers at the top. And hopefully by the end, you're going to feel better equipped. But again, 56, 57% of you are participating. I love the engagement, you guys. Thank you. This is like Merry Christmas and Happy Birthday to me. Love the participation. Again, how confident are you in your ability to speak effectively with your patients about measles, pertussis, and varicella vaccinations? So we're going to go ahead and give you a countdown of 5, 4, 3, 2, 1, and we're going to go ahead and end the poll and show the results very quickly. As we share those results, you can see that folks have been very confident, 11%, confident 37%, somewhat confident 32%, slightly confident 13%, and not confident about 6% of you. So we'll stop sharing that, and thank you for responding. We're going to go ahead and move on to our next slide, and hopefully those numbers will change by the end because we have Dr. Jasjit Singh with us today. Pediatric Infectious Diseases with CHOC, that's Children's Hospital of Orange County, Children's Hospital with us today, and Rady Children's Health. Dr. Singh, please introduce yourself as you like and dive right into your presentation.
Thank you. That was perfect. Thank you for that introduction. And thank you to all my friends at CDPH for all your hard work and for hosting these educational sessions. And actually, a special thank you to the person who submitted that very youthful image of me for the flyer. I really appreciate it, and I've been enjoying it. But all joking aside, actually, it prompted some reflection that I'd like to share with you before we get started here. I was thinking about my younger self and wondering what she would say about my doing talks on vaccine preventable diseases at this later juncture in my career. I was wondering if she would be disheartened by that. And I can tell you that that younger version of myself was very excited to share my training experience with younger generations of trainees. And that's because my residency experience was so colored by invasive Hib disease. We were very good at doing spinal taps. And the reason for that is that we saw so much meningitis due to Hib and due to pneumococcus. We were incredibly afraid of losing a child's airway due to epiglottitis from Hib. And we saw a lot of other invasive Hib disease at that time. And so I was really excited to share afterwards with subsequent generations of trainees the fact that they may never see a case of invasive Hib disease during their residency. They may never even see one during their whole career, which turned out to be the case. And to share with them that that's because during the latter part of my residency, the Hib vaccine came out in the 1980s. And so much of that suffering disappeared. Amazing. A few weeks ago, a medical student came up to me and said, Dr. Singh, I admitted a patient last night with vomiting and diarrhea, and she tested positive for rotavirus. And I thought to myself, my goodness, during my training and for many years afterwards, we saw a lot of rotavirus disease. There were times of the year, weeks at a time, when the wards would be dominated with kids with diarrhea and dehydration due to rotavirus. And now this medical student was telling me this with the excitement of a medical student who has made her first exotic diagnosis. How great is that? That we've gone from a frequent illness needing hospitalization to one that's considered an exotic diagnosis. So in that framework, I'm going to get started with this discussion about vaccine preventable diseases and some of the clinical features that I'd like you to recognize if you're thinking about them, some ways that you should think about for diagnosing, and really importantly, how to talk to parents and families about some of these diseases, even if you haven't seen them yourself, and how to talk to them about the vaccines that can prevent those diseases. Next slide. I have no disclosures. Next slide. We're going to start off with a discussion about measles because it's been in the news quite a bit lately, as you all know. Next slide. I really like these epidemiologic slides that show us the burden of disease pre-vaccine and what we've accomplished more recently. I think it's very gratifying and really gives us a lot of information. Next slide. If we look, though, at the last 25 years, we can certainly see in a blown up version of that last curve that there is a general trend upwards in terms of our yearly measles cases here in the US. And certainly we know that due to the outbreak in Texas, this year we're on track to have more cases than we have had in the last 30 years. And we are approaching the possibility of losing our elimination status. Next slide. And part of that, of course, entails looking at our MMR vaccine coverage for kindergartners. So if we look at the map on the left from 5 years ago, you can see that there is quite a bit of blue. And in this case, blue represents more than 95% coverage, which we think of as that wall of herd immunity for a highly contagious virus like measles. And if you move over to the map on the right, 5 years later, you can see that there's a lot less blue. And even in a place like California, which is fortunately still blue, we know that it's not completely homogeneous across the whole state, right? So although we have good coverage altogether, there are certainly pockets of under-vaccination. And I know that we have those here in Orange County. Next slide. So what happens when these susceptible unvaccinated people travel is that they may encounter measles. And this is WHO data from pre-pandemic, but really what I want to emphasize here is that the darker areas represent higher measles incidence. That there is a lot of measles in much of the world, some places where you might expect to find more disease, such as countries in Africa or in India. But I don't know if many people appreciate how much measles there is in Europe, for example. And because of that, next slide, and the fact that people are traveling more now post-pandemic, we have people who are susceptible because they haven't been immunized, traveling to those countries, picking up measles, returning home, and spreading it to subpopulations which may be under-vaccinated. And when we think about where we do travel frequently from the US to Europe. And that is one of the more common areas for importations of measles cases. Next slide. So the reason that we get that spread, of course, is that we know that measles is a very, very contagious disease with a reproductive number of 12 to 16 and a secondary attack rate in susceptible household contacts of 90%. So airborne transmission, extremely contagious. Next slide. The incubation period is 10 to 14 days. And it starts off with actually low-grade fevers, which over the first few days start to increase until you get some fairly high temperatures. We have the C's that we learned about, cough, coryza, conjunctivitis. And most of us learned about Koplik spots, but I hear frequently people say, well, I really don't know what they look like. I haven't seen them. Next slide. Here is a great picture from the Red Book Library, and this is what they look like when I've seen them. You really have to look hard at the buccal mucosa, and what these lesions look like are small grains of sand on an erythematous base. Now, what Koplik spots represent are an enanthem. And an enanthem is a mucous membrane rash, if you will, and it starts a day or two before the exanthem or the skin rash. You have to look hard for it, as I said, and it will disappear pretty quickly after the exanthem starts. So something that can be very helpful if you do see it, but hard to see. Next slide. So that rash then starts 2 to 4 days after the prodrome. And you remember with measles that it's a maculopapular rash that becomes confluent. And that piece it differentiates it from other illnesses such as rubella, where the rash does not become confluent. The rash begins on the face and progresses downwards and then fades in that same order, top to bottom. And remember that your patient is going to be contagious 4 days before until 4 days after the onset of that rash. Next slide. And here are pictures of that rash. And what I learned during our Disneyland outbreak about a decade ago down here is that the rash really looks different on different skin tones. So many of us are familiar with the pictures on the left and the right here, fair-skinned children, that bright red rash that we learned about. But when you get to darker skin tones, it is harder to appreciate and can have more of a brownish discoloration. Next slide. I think that's easier to see in this picture of this little girl, where you can really appreciate that it's more of a brownish discoloration. You can also see in this picture her conjunctivitis, the fact that her eyes are watery and runny, as is her nose, and she looks pretty miserable. And so I want you to compare that to the picture on the left, that bright red rash on a more fair-skinned individual. Now, the clinical case definition: fever, which can be high, rash, and at least one of the 3 C's. And having seen measles now during my training in New York with that blip in the 1989-90 area, as well as our Disneyland outbreak, I can tell you that cough is really, really quite consistently present. Next slide. So this is data from our Disneyland outbreak. And one of the things that we experienced at that time, and I'm sure they're experiencing right now in Texas, is that when you have a measles outbreak in your community, everyone is coming in for measles testing with a fever and a rash. And of course, there are other causes of fever and rash. So we looked at our data to try to find the features that were most likely associated with a positive measles test in the red. And when we did that and looked at different symptoms, you can see the fever for more than one day with the rash that starts on the face and then progresses in that downward fashion, along with respiratory symptoms, were the best constellation to predict a positive measles test, which were the cases in the red. Next slide. Now, there are lots of causes, as I mentioned, of fever and rash. This is by no means a comprehensive list, but many of the other kids turned out to have parvovirus, which is more commonly seen in school-age kids. They get that slack cheek appearance that you can see here in the photo, often a lacy rash on their trunk. Younger children might have roseola, where they have high fevers, and the rash that often appears as their fever is abating starts on the trunk and spreads outwards. Enteroviruses, very common, can have a plethora of rash manifestations and can have mouth lesions with hand, foot, mouth disease. And I've certainly gotten many calls over the years. Well, I don't know what Koplik spots look like, and there's something in the mouth here. Could this be Koplik spots? But I think in California, if I were to ask one of my residents, what does this child have? They have a high fever, they're fussy, they have red eyes and a rash. They would say, next slide, Kawasaki's disease, because we see a lot of it here. And there is a lot of clinical overlap between these two entities. One difference that I'll mention is that the measles patient I showed you was sort of wet and drippy, and the Kawasaki's patients often are not. But otherwise, there's really a lot of clinical overlap. So much so that during the Disneyland outbreak, our first measles case here at CHOC was sent over from another hospital for evaluation and treatment of Kawasaki's disease. Next slide. So, measles testing. When do you have a high suspicion of measles for your patient? If they're unvaccinated, certainly, and if they've traveled internationally, if they visited an outbreak community, if they've been in contact with somebody with measles. Those are things that might increase your suspicion that your patient might have measles. Next slide. So what are you going to do to diagnose it? Well, you're going to collect either a nasopharyngeal or an oropharyngeal swab and urine for measles PCR. Now, the CDC recommends that we also check measles IgM and IgG. I can tell you that those IgMs have both false positives and false negatives. And down here in Orange County, our health department actually is not as interested in the serology. They really want us to get those samples for PCR testing. The important thing here is that if you do have a suspect measles case, you want to let your health department know right away. And they can also help you with this testing. Many of our health departments in California are able to do this testing, and they can do it with a much quicker turnaround time than commercial labs. The other thing they can do, which we found helpful with an interesting case just a couple of weeks ago, is that we had a young child who had gotten MMR vaccine about 2 weeks earlier come into our ED with fever and a very worrisome rash. And that child was tested at the health department with a positive measles PCR, but they were able to further ascertain that it was actually the vaccine virus. And that helped all of us a lot. So do keep that in mind, that you can have a positive PCR if someone has been vaccinated in the last 3 weeks. Next slide. So in the measles cases, I've seen otitis media, pneumonia, croup, diarrhea are all very, very common. Hospitalization rates traditionally have been about 25% in the US. With this current Texas outbreak, the CDC is posting that it's about 12%. Acute encephalitis in about 1 out of every 1,000 cases or so. And of course, we know about the fatalities that have been ascribed to that Texas outbreak. I do want to also mention SSPE, or subacute sclerosing panencephalitis. I had really been hoping that I was going to get through my entire infectious disease career without ever having seen one of these. And unfortunately, I did a few months ago, and it is devastating. It is a very rare but awful complication of measles. Occurs in children who had measles at an early age. This particular child had contracted measles before the age of 1 in another country. And then 8 to 10 years later, these children develop progressive degenerative neurologic symptoms that just progress inexorably forward. And it is just a horrible thing to see. Next slide. So if you too have that suspect measles case, you want to identify, isolate, and inform. So if you can, get that child into an airborne isolation room as soon as possible. Now, if you're seeing this child in a clinic or an outpatient setting, you certainly want to get them out of the waiting area, masked, into a private room with the door closed. If you have a HEPA filter, that's great. And once again, you want to notify your health department, and if you have an infection prevention team as well. If you have a heads up, it's also great if you can see these kids outside. We certainly did that during our Disneyland outbreak, and our pediatricians got very good at going out to the car to see some of these kids that they were concerned about. So since we have great weather out here in California, it's a great thing to take advantage of. Next slide. If you do have an exposure, though, it can be amazingly resource intensive. So what you're going to need to do is go through your entire list of exposures and figure out who is susceptible. And once you do that, then you need to determine which of those people are eligible for an MMR vaccine. And you want to give that within 3 days. If they are high-risk individuals, then you might need to think about giving an immunoglobulin product, which you would want to do as soon as possible, but certainly within 6 days of that exposure. And as I mentioned, these are extremely resource intensive. So one of the measles cases that we've had in the state this year was someone who had come to our emergency room several times. And because of that, we had over 500 exposures. And you can imagine the amount of time it took to go through all of those cases. And that's actually not counting the family members that come along to a pediatric hospital, of course. Then the amount of time and the cost of the immunoglobulin products that we didn't have enough of, so we had to procure them from other places. So altogether, when you counted up those costs, it approached $100,000 for just this one exposure from this child, and an immense amount of time and energy that, of course, happened on a weekend, which these things tend to do. Next slide, please. So we would like to avoid all of that. And fortunately, we have an incredibly good vaccine with an effectiveness after 1 dose of 92 to 93%, and after 2 doses, 97%. We have an excellent safety profile over 50 years. We do get fevers. 5 to 15% of kids will get a fever, high fever, occurring 6 to 12 days after their vaccine that lasts usually just a couple of days. We will see an additional febrile seizure per about 2,000 to 3,000 vaccinees, transient rashes in about 5%, and some more serious reactions are less common, like transient thrombocytopenia in 1 out of about 30,000. But I do want to remind everybody that the vaccine virus cannot be transmitted. So sometimes people are concerned about giving a live virus vaccine. to someone in the household of an immunocompromised individual, but you do want to vaccinate that person because you want an extra layer of protection since the immunocompromised person can't themselves be vaccinated. So that's an important thing to keep in mind. Next slide. But as I mentioned, when we look at our US two-dose coverage of MMR for kindergartners, you can see that over the last 5 years, that coverage has decreased from over 95%, where we'd like it in 2019-20, down to our most recent data of 92.7%. Next slide, and I think some of this is really due to a more recent phenomenon of making an equivalency between vaccine adverse events and the risk from the disease itself. Now, this is a nice visual that I like, posted recently by Caitlin Jetelina. The original data, I think, is from the New York Times, and it really shows, I think, in a very easy visual form, the difference between the effects on 10,000 people who get measles disease and what problems ensue from that, compared to the effects of 10,000 people who get the MMR vaccine. Now, of course, we know that nothing, even our really good vaccines, are completely risk-free. They are not. Nothing in medicine is completely risk-free. But those risks are very small, and they are certainly not equivalent to the risks from the disease. Next slide. So in addition to our routine recommendations, we do have additional recommendations for international travelers, particularly for children. And I think that people don't remember to think of MMR as a travel vaccine. But we do want to give our infants who are 6 to 11 months of age an extra dose of MMR vaccine before they travel, and they still need their typical 2 doses on the regular schedule. For children who are 12 months of age and older, we want them to get that second dose if it's been more than 28 days since their first dose, so that they can have that extra protection during their travel, and they will not need an additional dose after that. So I think this is really important, and actually that big exposure that I told you about was from an 11-month-old child who traveled internationally, had not gotten this travel vaccine, contracted measles while there, and then came home and exposed those individuals in our ED and in some other places as well. Next slide. This is another topic that I think we haven't emphasized enough, which is that scientists have known for many decades that measles seems to blunt our immunologic response to other infectious illnesses. So a group of researchers studied this, and they looked at measles in the populations and then looked at waves of infection following measles and found that there were more infections and deaths from other infectious causes following measles in a population. And that lasted for about 2 years, and they gave it the term immunologic amnesia, not really found with other illnesses. And then they took a deeper dive into that a couple of years later, and they looked specifically at the blood of some of these kids, and they showed that a good percentage of them wiped out their pathogen-specific antiviral antibodies. And we know that their cell-mediated immunity also was altered, so that in essence, their immunologic repertoire was kind of wiped clean for a while, and they had to start from scratch. So I think that this is very important because there is a worry out there that vaccines are hard on the immune system. And I think that this data shows us very clearly that measles as a disease really gives your immunologic system a good beating. Next slide, please. So we're going to transition over to pertussis or whooping cough now for a few minutes. Next slide, please. also another highly contagious vaccine preventable illness. This is a graphic from the CDC that I like these graphics, and I think where they can be very helpful for us in terms of communication is that they can be put up as a poster in a waiting area or supplied in exam rooms while patients are waiting. And what they do, I think, is they, prompt a little bit of thought about these vaccine preventable illnesses. And let's face it, we are all very pressed for time during our busy days. And so I think that these can sort of jumpstart some of these conversations and give you a little bit of a head start in terms of your discussion. So some of them are just really well done, and I hope that they're being well utilized in those spaces. Next slide. So another epidemiologic slide that I love, showing what the burden of disease was early in the past century and how far we've come. If you look at the insert over the last 25 years or so, you can see that, like many other illnesses, pertussis went down during the pandemic. And then you can sort of see in the US data that sharp incline upwards with the provisional data that we have so far. Next slide. And more importantly for us, we have our CDPH pertussis snapshot here. And I think it shows you again how pertussis went down, like many other illnesses during the pandemic, and how now we are seeing an increase approaching that of our pre-pandemic numbers. But fortunately, at least here in California, not exceeding pre-pandemic numbers like pertussis has in other jurisdictions such as New York. Next slide, please. So clinically, what do we see? After an incubation period of 7 to 10 days, we think of pertussis as occurring in 3 clinical stages. So the first stage is runny nose, mild cough. Really, it looks like any other URI. There's nothing to differentiate this specific stage and let you know that it's pertussis. But then we get into the paroxysmal stage. And that's when you start to have the severe spasms of cough. And that cough really is with one breath. And it's associated with very thick mucus. It almost has a ropey consistency. And after that, cough, 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 the person takes a deep inspiration and a whoop, often with post-tussive emesis and, quite frankly, exhaustion after all of that. And then you go to this rather prolonged convalescent phase. Next slide. And that's really shown well on this CDC timeline, where you can see that that convalescent stage can last weeks to months afterwards. And that's where that nickname of the 100-day cough comes from. Next slide. So the problem with all of this is that adolescents and adults have waning immunity, they can get pertussis and have a very prolonged cough. They probably won't end up in the hospital, but the issue is that they are the reservoir for the infection for our infants, and our infants don't handle pertussis very well. So they may not have a whoop. They usually don't, actually. But what most of the babies will do is they will have gagging, choking, gasping, and apnea spells with color changes. And next slide, because of that apnea, oxygen desaturations, about a third of young infants will need hospitalization. And other complications that those babies can have are pneumonias, either primary pertussis pneumonia or bacterial superinfections. They can get seizures in about 2% of cases, encephalopathy less than 1%, and the mortality in the tiniest of our infants is about 1%. And that is often due to pulmonary hypertension. So what happens is, you'll remember that these babies can have exceedingly high white counts, 60, 70,000, 100,000, with a right shift, so a lymphocytosis. And all those white blood cells can actually clog up their little tiny pulmonary venules and cause sludging and pulmonary hypertension. They can be very refractory and difficult to treat. Next slide. So in terms of diagnostic testing, we used to rely on culture, and I'm glad we don't have to anymore because this is a very fastidious organism, Bordetella pertussis, and difficult to grow in culture. So we're lucky now that we have a great PCR that can be done in the first 3 to 4 weeks of illness and is much more sensitive. Next slide. This nice CDC graphic really reminds us to treat early if we don't have our testing back, to treat empirically. And we want to treat patients who are a year or older within 3 weeks of cough onset, but some of those high-risk patients, like the babies under 1 year of age, pregnant women, other high-risk individuals, we probably should treat within 6 weeks of cough onset. Next slide, please. So remember, of course, to think about post-exposure antibiotic prophylaxis. This is a very contagious illness, so all household contacts of a pertussis case, regardless of immunization status, need to be treated within 21 days of exposure. So that would be household contacts, daycare contacts, and then other high-risk people who may have been in contact as well as are listed here. Next slide, please. And then, of course, we have our very important Tdap recommendation. In addition to sort of routine recommendation for children, we recommend Tdap for all pregnant women between 27 and 36 weeks gestation with every pregnancy, even if they're only a year or two apart. And this is such an effective means of protecting our young babies. What we do is, of course, we immunize mom and we let her immune system do all that work to make great antibodies, pass them along through the placenta to the baby, just handing all of those great antibodies passively over and protecting that baby for the first few months of life. And this is an incredibly effective strategy for so many illnesses. We have been able to virtually eliminate neonatal tetanus in many parts of the developing world by using this strategy. And of course, in this country, we are also using it for influenza, RSV, COVID. It is just an incredibly good way to protect babies from these illnesses in the first few months of life when they're really at highest risk from having trouble handling those infections. We have seen that this strategy is extremely efficacious and it's safe. Next slide. So when we look at how well we're doing, though, it's not as good as we would like, I would say, in terms of vaccinating pregnant women. So this MMWR, which was published in April 2023, shows us that 55.4% of women who were pregnant had received the Tdap during pregnancy. And that percentage is even lower for some of the other vaccines that I recommended. So clearly, we would like to do better than that for such an effective intervention. Next slide. And this is also data that shows us that unfortunately, in subsequent progressive years, that coverage in pregnant women has actually fallen, and that we have discrepancies depending on our patient's background. So clearly we have, I think, our work cut out for us. I hope somebody can maybe put in the chat for us. There is some California specific data from 2021 survey looking at these same kind of numbers. Next slide, we will change channels once again and talk a little bit about varicella or chickenpox, another highly contagious vaccine preventable disease. Next slide. And of course, we remember that this is also airborne spread. And the disease actually gives us that rash. Many younger doctors and nurses may not have seen it, but in its full-blown form, we have a very pruritic rash, vesicular, 250 to 500 lesions in varying stages of development. So it starts off with papules rapidly becoming very thin-walled vesicles with clear fluid. It becomes cloudy, they rupture, crust, and scab, along with fever and other systemic symptoms. Next slide. We have a great vaccine to protect us against varicella. So against household exposure, the efficacy against protection against infection is about 70%, but more than 95% against severe disease. And here's another message that I think we need to get out there is that for some of our vaccines, really what we want to do is maybe not protect against every single infection, but what we really want to do is protect against severe disease and keep people from having to be hospitalized or end up in an ICU because of an infection. And I think that was the point of that great Wild to Mild campaign by the CDC for influenza vaccine. So that is very much the case here as well. Really, really great protection against severe disease. So when we have varicella in vaccinees, otherwise known as breakthrough varicella, it is very much milder. So you can see as compared to 250 to 500 lesions, we just have kind of a handful, 16 to 30, much less fever, more rapid recovery, still potentially infectious, but much less so. Next slide. So in case some of you haven't seen varicella, this picture on the left is in a child with full-blown varicella, wasn't vaccinated. You can see the lesions at different stages, which is very important. And that first vesicle, you can see in a few of these lesions, textbook description is dewdrop on a rose petal. And it really does kind of look like that on bare skin. The picture on the right for you shows what varicella might look like on somewhat darker skin. And this is actually breakthrough varicella in someone who has been vaccinated. And I think you can appreciate that this is just milder and much more sparse in terms of lesions. Next slide. So the CDC also has these nice graphics reminding people to think about breakthrough varicella with some of these milder manifestations, with some examples of other rash illnesses that might look similar. We have these plastered all over our ED triage area because you do want to think about it and place people in appropriate isolation if needed. Next slide, please. So as I said, our vaccine is very, very effective. And so you can see here that with our vaccine, we have decreased varicella cases by 97+%, which is why so many of our younger physicians and nurses haven't seen chickenpox. And we also, as you can see, have a fraction of the hospitalizations and deaths that we used to have from chickenpox. So overall, it has been a very effective strategy. Next slide. And although the vast majority of kids with chickenpox will do fine, no doubt about that, there are some really, really serious complications of varicella. In my mind, the worst of which were some of those really terrible bacterial superinfections of the skin, particularly necrotizing fasciitis due to group A strep following chickenpox. Necrotizing fasciitis is what's known to the lay public as flesh-eating bacteria, and it was horrific. I would never want to see any of those again. Other severe complications include encephalitis. We would see terrible chickenpox in some of our immunocompromised children, particularly those with leukemia. We would see really severe hemorrhagic varicella. In adults, pneumonia is the most frequent complication. And of course, you know that adults can get shingles and really suffer from post-herpetic neuralgia. So things to think about even with chickenpox. Next slide. Exposure management. The Red Book now has this great resource, which are algorithms for exposure management for various illnesses. And I think it's really helpful because you'll notice that it's a little bit different from the measles one. So for a healthy person greater than a year of age, within 5 days of exposure, you're going to give vaccine. And for our high-risk individuals, you are going to think about an immunoglobulin product within 10 days in this case, or you might be able to give Valtrex on days 7 to 14. Next slide. So I want to spend just a couple of minutes here talking about additional strategies when you're talking to parents who have concerns about their vaccines or are hesitant. And I know you've had some great talks, Dr. Hempstead and others who spent more time on this, but from my point of view, what I've found is that the reasons that people might be hesitant are very heterogeneous. And some of the top ones are that they really may not have enough information about vaccines and really about how these vaccines work, and we can often help with that. They certainly may not have an understanding of the severity and communicability of vaccine preventable diseases. We know there's a lot of misinformation out there. And as I mentioned, there has become this sort of equivalency of vaccine serious adverse events and illness adverse events, and they are just not equivalent. There's a lot of mistrust. This next one, I found a lot of people concerned about the number of injections and the fact that they're worried about overwhelming the immune system, which of course is not going to happen. And honestly, we are all strapped for time, and sometimes we don't have enough time for the length of the conversation that really should occur. Next slide. So I think that, you know, that whole risk-benefit ratio that has gotten skewed, we have to really be able to explain how severe some of these diseases can be, and particularly when people are not seeing them in the community, because we have been victims of our own success and they haven't seen how bad some of these diseases can be. There are other people, though, that are certainly going to focus on the socio-political aspect of all of this, which is a sad thing, I think. Public health and vaccines should not be political issues. But we are seeing that, and we are hearing more about individual rights, and I think it's termed medical freedom, and having it framed that way. Next slide. What I will say, though, is that it really is important out of that myriad of reasons to try to figure out what it is that the parents or family is hesitant about, because in your limited time, you're going to have a very different conversation about concerns about autism versus concerns about overwhelming the immune system versus concerns about formaldehyde in vaccines. So it really does help to really drill down and find out where that hesitation lies. And then, of course, I know, you know, for myself, I have to remember to be patient. And I have certainly over the years learned how important personal stories are. I think we were very data-driven at the beginning of all of this, but we've all come to appreciate that we can share some of those stories that are emotional, and they can have a big impact. So next slide. Finally, I want to leave you with some of my favorite resources. A special, I think, plug for the Vaccine Education Center at CHOP. I think that Dr. Offit has just done such an amazing job of compiling resources for all of us on just a host of topics that are vaccine related. And I know that our CDPH colleagues are going to share more resources with you. And I just want to leave you with one final thought, you and that younger version of myself, that certainly I know that we may be feeling right now that things are challenging, they are frustrating, they may be unnerving in a lot of ways, but I want everybody to remember that most people do want to get their kids and families vaccinated, that there are people standing up for science, that our professional societies and our medical organizations are united, putting out statements in a united way right now that I haven't seen before during my career, and that there are so many people like yourselves that are doing all the hard work every day of keeping our kids and our families safe. So I thank you, and I'll turn it over to our CDPH colleagues.
Thank you, Dr. Singh. We're going to move to the next slide with a thank you for all of the preparation Dr. Singh has made in today's webinar, as well as these wonderful updates. We're going to move to our next slide, and we want to turn it over to Tarisha Gamboa for some more resources. Tarisha?
Thank you, Leslie. Hello, everyone. My name is Tarisha Gamboa, and I'm a health educator with the CDPH Immunization Branch, and I'll be going over resources and tools to supplement Dr. Singh's presentation and help you with your immunization practice. Next slide, please. I'd like to start off by sharing measles resources from our CDPH office. First, there is a video message from our CDPH director, Dr. Erica Pon, talking about the dangers of measles and how continued vaccination is important. And then next, we have our measles disease page on our CDPH website showing case rates in our state. And then a measles toolkit that contains flyers like these shown here and messages to get vaccinated. We will be having these in other languages coming soon, so be sure to check those links out and see what would be helpful to share with your patients and staff, and especially as traveling increases in the summer. Next slide, please. Next, we have vaccine education for pregnant patients. Here are 3 materials for patients to take home, and they're comprehensive of all recommended prenatal vaccines. They are all in English and Spanish, and free copies can be ordered using the links below. Next slide. Here are more CDPH resources. Most of these are found on our provider website, easyIZ.org. This right-hand image shows our homepage, which is linked at the top. From there, you can access the following pages. We have disease-specific pages for provider and patient resources on measles and pertussis, and then 2 main web pages providers can use for education on vaccine safety. The first web page is our parent education page with guides and communication tools when talking to parents. And the second web page is our immunization studies and references page, which includes links to scientific literature and trusted sources of vaccine safety that healthcare providers can review and reference. Next slide. And then onto some additional provider resources outside of EasyIZ. Shotbyshot.org is a CDPH partner and great resource for real accounts about vaccine preventable diseases. These stories are in video and written formats and a helpful strategy when talking to parents and patients. And these stories touch upon the real life dangers of not getting vaccinated. Other resources are healthychildren.org and immunize.org to review vaccine guidance and address parents' concerns with vaccines. And lastly, we've linked up below a study on vaccine hesitancy, specifically in refugee, immigrant, and migrant populations here in the US. And this information may be helpful when serving those populations, especially during these times. Next slide, please. Here, I'd like to share resources that help with communication about vaccines. Public Health Communications Collaborative is a learning and information hub for providing communication tools and learning opportunities to healthcare professionals. PCC published a guide for communicating more effectively about vaccines with tips and vaccine messages that resonate better with the public based on focus group findings. Some examples are pictured below, and you can find other helpful approaches on effective vaccine communications, webinar topics on this, and other resources on their website linked in the second bullet. And next slide. Continuing with more communication resources, Public Health Communications Collaborative also has a great tool for general public health messaging using plain language that's clear and easy to understand for developing communications. And then CDC also has print and media resources for you to share with your patients to promote vaccines. And then the last one here is the Association of Immunization Managers with great webinar series for increasing vaccine confidence. And I've put some screenshots of their videos below, and these are really helpful as they go through examples of messages and their findings on what works and what doesn't work in communication about immunizations. So check out all of those for yourself and your staff. And I believe that is my last slide, so we can go on to the next slide. And I should pass it back to you, Leslie. Thank you.
Thank you, Tarisha. So following today's webinar with the information you've been provided, we want to check in. How confident are you now in your ability to speak effectively with patients about measles, pertussis, and varicella vaccinations? Options, again, very confident, somewhat confident, slightly confident, and not confident. I'm seeing answers popping in with over 200 of you on the call. We're getting a wonderful response rate. Thank you for staying so engaged with us throughout today's session. And I even see an emoji pop up. If you want to just put an emoji, if you have benefited from attending today, throw an emoji up as well. We love to see those as others are getting their answers in. Great. Oh, this is wonderful. Thank you. And thank you for respondents coming in. We've got 60% now who have responded to today's poll, and that number is rising. Please take a moment. We're going to check this in just a couple seconds. We're going to give you the opportunity to add your input. How confident are you now in your ability after today's session? And we're going to go ahead and end the poll in 5, 4, 3, 2, 1. We'll end the poll with 68% of you have participated, and we're going to share those results for you so you can see not confident moved. There's 0% now. It looks like everyone has increased in their confidence, very confident at 31, confident 49%, somewhat 15%, and slightly 5%. And we are continuing to provide these webinars so you have tools in your toolbox, like the resources that Tarisha and Dr. Singh shared. So let's move on to our next slide as we check in on some Q&A. I want to thank Dr. Katarina Liu, one of our public health medical officers, for answering questions as we've gone along. And Dr. Singh, James is looking for a perspective to help guide conversations with parents who are willing to give some essential vaccines, but not all of the scheduled vaccines. If the goal is to protect children against the most contagious and most dangerous, how would you rank or tier vaccines in the current childhood schedule?
You know, I'm not sure that there's a one size fits all answer to that question. It really depends somewhat on the child's age and other risk factors, such as their overall health and maybe even in terms of what their household contacts are. But certainly I would say that, most children are going to be at risk for tetanus-prone injuries. That's important. If they're in the right age group, at high risk for Hib or pneumococcal disease, those are important. If you have an outbreak in your community of measles, chickenpox, those are extremely important. So I think that you sort of have to assess it a little bit individually and then kind of rank accordingly according to that child's risk. But those are some preliminary thoughts.
Thank you. There is a question. If someone gets a vaccine-derived illness, do they need to isolate from others in the household?
So a vaccine-derived illness. So I think they're referring to either MMR or chickenpox vaccines as the live vaccines. With the inactivated other vaccines, they would not be contagious in any way. In terms of MMR, as I mentioned, it's nice that those vaccine viruses are not transmissible. So even if that patient did have a little bit of a rash and fever a week after vaccination, like they might have, they are not contagious. Chickenpox, though, on the other hand, if you do have vaccine virus rash with full-blown vesicles. There are very, very occasional cases of transmissibility. So if you did have a high-risk person in the household, you might need to be careful with that, but those are few and far between.
Thank you. And Kelly has a question about chickenpox and shingles. If someone had chickenpox and shingles, is the shingles vaccine still recommended?
Yes, the shingles vaccine would still be indicated even if they've had chickenpox and or shingles.
Thank you. I want to thank everyone for attending. And Dr. Singh, thank you so much. We are at the top of the hour. Dr. Singh, any final words before we wrap things up as we move to our next slide?
No, just keep up all the great work that all of you are doing. I really appreciate it and appreciate all of you for being here with me today.
Thank you so much. And again, we want to highlight we have a CDPH immunization updates for providers webinar. Our next session, Friday, June 27th at 9 a.m. And the registration link is in the chat, along with the link to today's slide deck. The recording will be posted later. Again, our gratitude to Dr. Singh, and for all of you, thank you for your time, your attention, your attendance, and your questions. We want to wish you a wonderful Friday as we go into the weekend. And again, thank you for all the work that you are doing with your families and in your community. And with that, we'll conclude today's session. Thank you all.